Good afternoon. This is Jason Jones with the Community Technical Assistance Center, and I would like to welcome you to today's webinar, Fetal Alcohol Spectrum Disorders, Diagnosis, and FASD-Informed Care. This webinar will help participants get more information about fetal alcohol syndrome, as well as the spectrum that's within it. Before we get started, I want to take a moment to orient everyone to the WebEx system so you know how to participate in today's event. Please note that upon joining the webinar, you have been placed on mute to avoid any background noise that may distract others from listening to the presentation. If you come across any technical issues during today's event, please chat to the host who will be able to assist you. You'll have the opportunity to submit questions for the Q&A portion of today's presentation by utilizing the chat box feature, which is located on the right-hand side of your screen. If it is not visible, click the dialog bubble on the top right toolbar and it should appear. In order to ensure that we are able to answer as many questions as time permits, we are requesting that you send in your questions at any point during the webinar, and we will address them during the Q&A portion of today's presentation. We are very excited to have with us today Ms. Lynn Cole and Dr. Christy Petrenko from the University of Rochester Medical Center. Once again, thank you for joining us. I will now pass it along to Lynn and Christy to get us started.
Hi there, this is Lynn Cole, and Christy and I are very happy to have the opportunity to present to you all today. I am a pediatric nurse practitioner by training, and I'm also the director of clinical services for developmental and behavioral pediatrics here at University of Rochester. And Christy will fully introduce herself later in the talk, but she and I have worked together here at University of Rochester to expand from really only having a research component to having a more comprehensive diagnostic and clinical care program through the medical center in collaboration with Mount Hope Family Center. And so we're really excited to present to you today and hope that this will be the beginning of expanding access to services and supports across New York State. So, I'm going to try and change the slides. Okay, so I'd like to start with this initial slide because I want to talk about the concept that fetal alcohol spectrum disorders are really an umbrella term. So fetal alcohol spectrum disorder is not the diagnosis. It's an umbrella term that includes multiple different diagnoses. The most common, or the most well-known of which is fetal alcohol syndrome. And if you look at that tip of the iceberg above the water, that's really what we think of as in terms of fetal alcohol syndrome. Really, the majority of diagnoses fall in this graphic below the water, and we'll talk more about that and why that is as we go on. A little trouble changing slides, I apologize. Here we go. So this here is a slide that really shows what the diagnoses are within this umbrella term. So we're going to talk about fetal alcohol syndrome, or FAS. We're going to talk about partial fetal alcohol syndrome, and then we're going to talk about a concept called alcohol-related neurodevelopmental disorder. If you'll notice, within each of these categories are different symptoms. So which diagnosis you end up having really has to do with how many of the symptoms a child has or an adult has. All of these, though, if you look across the top, all have neurobehavioral impairment. And so we'll talk more about how that diagnosis is made and then what the implications are for treatment. So before we get into this, I want to talk a little bit about why we think knowing about FAS and FASD is so important. Really, we think this is so important because this is a very common disorder. In the general U.S. population, it's thought that about 6 to 9 children per 1,000 have full fetal alcohol syndrome. But if you look at the broader spectrum, somewhere in the range of 2 to 5% of children are thought to be able to be diagnosed with this disorder, although most are not diagnosed. There are certain special populations with which many of you may work with. So it's particularly important for providers who work with children who are in foster care or other out-of-family care situations. It's really important for providers who are working with Aboriginal populations to know about this, as well as for folks working in mental health populations or in correctional populations, because these are quite high in those populations. When we think about drinking patterns, there's a lot of misinformation in the United States medical system about what constitutes drinking during pregnancy, and there's a lot of misinformation about whether it's okay to consume alcohol during pregnancy. What we know is that definitely heavy drinking is associated with brain alterations and cognitive deficits, as well as these characteristic behavioral problems. We know that binge drinking probably leads to the worst outcomes, but this can only be, when we talk about the diagnostic criteria, you'll note that just a couple episodes of binge drinking can really be associated with significant neurodevelopmental differences. In studies of moderate drinking, and that's about a drink per day, human studies have showed mixed results, but animal models show that there's clear damage to brain and that there are associated behavioral impairments, even with what's considered moderate levels or 1 drink per day. And similarly, or not similarly, lighter sporadic drinking, which is less than that, 1 to 4 drinks per month, has not been well studied yet in animal models. But all of this is to say that the standard response about what amount of alcohol is okay during pregnancy ought to be 0, and that's not always the message that women are getting. So next we'll talk a little bit about the diagnosis. There are a few important factors to recognize, though, in terms of things that may affect the outcome of the infant. Because what we know is that alcohol doesn't affect every baby in the same way. So we see many children who have similar alcohol exposure history, but who may have very different outcomes. And there's a lot of research going on looking at genetic factors that may play a big role in how alcohol exposure is shows up in a baby, but there's also some both maternal factors and environmental factors that we know contribute to less positive outcomes. So as women get older in terms of their age when the baby is born, as well as later pregnancies for a woman, tend to have worse outcomes for the baby. Similarly, women who have nutritional deficiencies or low BMI are likely to have poorer outcomes for the baby, and also depression or stress during the pregnancy or low educational attainment. There's also things that can further compound alcohol exposure in terms of the environment, and that includes things like poverty, social isolation, maltreatment or neglect in the child. And so these are all important factors that contribute to the outcome of the child. In this era where there is a lot of publicity around the use of substances other than alcohol, especially narcotics, it's important. Families will often ask us, about opiates. Families will often ask us, well, was it really the alcohol or was it the other substances that were utilized during the pregnancy? And if you look on this slide, you'll notice that alcohol is the one substance that has strong effect on almost all areas of that are measured here, including the fetal growth, abnormalities of the physical child. Withdrawal is one area that alcohol does not have an effect, but there are long-term effects for the child and growth, behavior, cognition, language, and achievement in a way that is not noted in all of these other substances. So diagnosis. Diagnosis is a challenge, and this is something that people often have questions about. And there are a number of reasons that the diagnosis can be challenging. So there's a number of different diagnostic methodologies. We're going to talk about the 2 that we're using here in New York State. We know that it's often difficult to obtain alcohol exposure history that's accurate. A third thing that makes diagnosis particularly challenging is that most affected children do not have facial and growth symptoms. And so that is a common misunderstanding of many people working with children, and so that's something we'll talk about today. And then finally, the CNS symptoms that we see in children with FASD can overlap with other developmental disorders, and so it's really important to have a diagnostic system that can separate those things out. So we're going to talk about a set of criteria called the HOIME criteria. We'll also talk later about some new criteria that's been proposed in the DSM-5. And so in the HOIME criteria, there are 5 critical areas that we look at. We look at the alcohol exposure itself. We look at facial features, growth, brain abnormalities, and neurobehavioral symptoms. And we're going to walk through each of these so that people have an idea of what is looked at when you make a diagnosis. So the first thing is we look at the alcohol exposure itself. And when we're thinking about diagnosis, alcohol exposure is either documented or undocumented. So documented is alcohol exposure that has been disclosed by the biologic mother, that has been shared in a medical record, or that somebody has witnessed during the pregnancy or during the 3 months prior to a positive pregnancy test. So this is recognizing that many women in our society consume alcohol prior to recognizing they're pregnant. And so there's often a critical period before women realize that they're pregnant where alcohol may be consumed. And if you look at the criteria for how much is consumed, it's really fairly minimal. So we're talking about greater than or equal to 6 drinks a week for greater than or equal to 2 weeks. That's really just a drink a day. Or 3 or more drinks on occasion for 2 occasions. So when we talk about binge drinking, that's what we're talking about, is 3 or more drinks. The other ways that it can be documented is through legal problems or alcohol-related social problems. There's a number of sensitive ways to ask about prenatal alcohol exposure. One of the things that we feel really passionately about is being respectful of the biologic mother. So what we know is that women don't drink with an intent to harm their baby. And so it's really important to ask about prenatal exposure in a sensitive way to understand pre-pregnancy alcohol use, timing of pregnancy confirmation, and what the alcohol use might have been prior to pregnancy discovery. It's also important to ask about other health behaviors. So we know that women who are experiencing domestic violence, for example, are at increased risk for alcohol use during pregnancy. So after we determine whether alcohol exposure is confirmed or just suspected, we next look at facial dysmorphology. And when we look at facial dysmorphology, we're looking at 3 things. We're looking at the size of the eyes, we're looking at the thinness or thickness of the upper lip, and we're looking at the flatness or bumpiness of the philtrum. And so I'll show pictures of those so that you can see. So when we see children for diagnostic evaluation, we actually measure the palpebral fissure length and plot it on a growth curve in order to determine whether it's average size, smaller than average, or larger than average. Next, we rank lip and philtrum. And so we note, for example, if a child has a very thick lip or bumpy philtrum, that would be down towards a 1. A 3 would be an average lip and philtrum, where the lip is very distinct. There's a cupid's bow in the middle, and the nares show a clear and distinct margin that goes all the way up to the nose. So this, and then all the way up at a 5 would be a child who has a very flat philtrum and has a very thin upper lip. So rankings in the area of 4 or 5 are considered to be consistent with the dysmorphology seen in children with prenatal alcohol exposure, whereas 1 through 3 is felt to be typical. And so this is just some examples of children who do have facial features across different genetic backgrounds. So this is seen similarly in children regardless of race or ethnicity. So the important thing to recognize, though, is, like I said earlier, is that most children with prenatal alcohol exposure do not have these facial features. So these are not required in order to make a diagnosis. So the next thing we look at is growth, and we're looking for growth including height or weight that is less than or equal to the 10th percentile. It can be any time starting at birth through the present, and that is plotted along an appropriate growth curve. So when a child is seen in a diagnostic clinic, we would typically look at height and weight measurements starting at birth and look at growth charts throughout their childhood. For babies that are born prematurely, it's important to look at prenatal growth by plotting their birth height and weight on a gestationally appropriate growth curve. Next, we look at brain abnormalities. The most common brain abnormality seen is a small head circumference. So that's a head circumference below the 10th percentile. It's also possible for children to have structural brain abnormalities that might be found on an MRI, although it's important to know that MRI or other brain imaging is not part of the diagnostic process and is not required for children who are known or suspected to have a fetal alcohol spectrum disorder. The other more common thing to see is recurrent seizures that are not febrile seizures, but a seizure disorder or epilepsy. And so what we do is we utilize this algorithm. So starting with signs and symptoms of alcohol exposure, we decide whether the alcohol exposure is documented or undocumented. From there, we look at dysmorphology, facial evaluation. So did the child have two out of the three facial features? If positive, we look at the neurobehavioral features that Christy will talk about in just a couple minutes. And from there, we go down and look at height, weight, and head circumference. And so depending on which direction a child goes down this algorithm, we're able to determine the diagnosis. One thing that's really important to notice is that for children who do not have confirmed alcohol exposure, so there was not anybody who witnessed the birth mother drinking during this pregnancy, or that the birth mother did not disclose this, is that for a child to receive an FASD diagnosis, the child must have both facial features, neurobehavioral features, and small either height, weight, or head circumference in order to establish a diagnosis. So this is just another layout of what the different diagnoses might be and what are the features that are associated with that diagnosis, so that you can see that for a child with fetal alcohol syndrome, you have positive in the areas of learning and behavior, facial features, height and weight, and central nervous system abnormalities, where the other diagnoses, partial FAS and ARND, have part of those. And down here shows what the criteria are for FAS and partial FAS when you do not have documented alcohol exposure. So next I'm going to turn it over to Christy, who's going to talk about neurobehavioral impairment and FASD-Informed Care.
Thank you. So my name is Christy Petrenko. I am a clinical psychologist and researcher here at the University of Rochester, and I've been studying fetal alcohol spectrum disorders since 2003, and I'm particularly interested in intervention development. So I'm going to start by reviewing what we think about in terms of neurobehavioral impairment, in terms of what's required for diagnostic procedures, and then I'll focus on intervention as well. So here you see the criteria for neurobehavioral impairment, which is, as Lynn mentioned, in the, oops, I'm going the wrong way. Hold on just a moment. In this criteria would be the far left column. So as we go forward, there are three different ways that a child could meet the neurobehavioral impairment category. For children who are 3 and older, they could have global impairment, which is measured typically by IQ tests. They could have cognitive impairment, which there are 4 primary domains: executive functioning, learning, memory, and visual spatial skills. Or they could have behavioral impairment, as represented primarily by difficulties with self-regulation. For children with full FAS or partial FAS, they just need to have one of the different areas within a given domain, whereas alcohol-related neurodevelopmental disorder needs to have 2 within a domain. You need to have more evidence of impairment. So, for example, a child with ARND might have executive functioning and memory impairment. Now, for children who are under 3 years of age, they can show evidence of developmental delay to meet criteria for full FAS or partial FAS. For children who do not have the facial features and who may be at risk for alcohol-related neurodevelopmental disorder, they need to wait until they're 3 years old to establish that diagnosis. All right. So what do I mean? Like, how do we determine impairment? And so as is defined by the Hoyme criteria, the threshold for impairment is 1.5 standard deviations. And so there are different types of neuropsychological tests that we use in making a diagnosis, and they can present in different types of scores. But generally, we're looking around the 7th percentile, or a standard score of 78, scale score of 6, or a T-score of 35. So we're looking at children who are in the low end of the curve. So I'm going to talk a little bit about imaging and neuropsychological impairment in general for FASD to give a broader background. So this first image I have here are autopsy findings from 2 5-day-old infants. And then you don't have to really be a neurologist to know which one of these is from a child who was very heavily exposed to alcohol. You can see on the left that the child's brain has a lot of malformations, including incomplete separation of the 2 hemispheres. There are a lot of migration areas and other problems there. And, you know, this is one of the most severe cases that wasn't compatible with life. But most people who have a fetal alcohol spectrum disorder don't show quite to that extent of impairment. And the best ways that we can really study what does the brain look like and how does it function in your typical individuals with FASD across the lifespan is by using imaging techniques. And so there's been quite a lot of research over the last couple of decades using both structural, looking at how the brain is formed, and functional, so how it performs on tasks, imaging kind of protocols. I'm just going to highlight a couple of examples to give you a big picture sense of what this looks like. So this first image here is taking an average brain. And what it is doing is comparing a group of typically developing children and a group of children with prenatal alcohol exposure and looking at how they differ on average. And so wherever you see the red areas, those are areas where children with prenatal alcohol exposure have less brain. So you can see that these are all largely in the prefrontal cortex here, which is an area that's really important for executive functioning and regulation, and also here on the sort of parietal temporal junction, which again also relates to a lot of the spatial and other types of challenges seen in memory and things like that, which are very common in this population. So in essence, the children, their brains are narrower and a little bit more blunt in the front. This is an image from a functional MRI scan. And what the children had to do in this task was a spatial task where they saw little squiggly lines, and they had to determine whether they had seen it previously in that same location. And so the task was created to be equally challenging for children with prenatal alcohol exposure and control. So it was a bit simplified, and the goal was to make sure that both groups could achieve the same accuracy. And this is important for making interpretations. And so what we were able to see is that over here on the left is a brain of the average prenatal alcohol exposure participant, and these are just different levels of the brain, but you can see there are a lot of areas that are lit up that the children had to recruit in order to complete the same task. Over here on the right are different levels of the brain of a typically developing child. And if you take the prenatal exposure and you subtract the areas of controls, you can see the average brain. So everything here on the bottom that is lit up are areas where children with prenatal alcohol exposure needed more brain to complete the same task. So it's not surprising that when these children come home from school after a full day, that they're mentally and physically exhausted because they've had to work so much harder to complete the exact same things as their peers. Now this slide here that I'm showing you is a summary slide of the functioning of children with prenatal alcohol exposure across a wide range of functional areas. So for here on the left-hand column, you can see this is intellectual functioning. It goes across into areas of academic achievement. There are a couple of measures of language, memory, visual skills, and beyond. And so what you see, the yellow bars are your typically developing children, and they're generally in the average range. The green bars are the children with full fetal alcohol syndrome, and the pink bars are children with heavy prenatal alcohol exposure, but who do not have the facial features. And what you note is that both alcohol-exposed groups generally perform pretty similarly. So regardless of whether you have the facial features or not, these children are generally functioning quite a bit lower than their typically developing children, and on average across a wide range. Another point I want to make, though, is while children with prenatal alcohol exposure on average function lower than their typically developing peers, there's a lot of variability from individual to individual. What you see on this slide are just 4 examples of children we've seen over the last year or two, and their profiles of functioning similar to what you saw on the prior screen. So we have some children who are very average functioning in terms of their intellectual abilities, as you can see in these 2 top children, but there are many areas that they struggle with. For example, with social communication, executive functioning, learning and memory, attention are all very commonly impaired for these kids. And their overall sort of adaptive functioning, or their ACT-like age, typically is lower than you would expect for their chronological age. There are also other children who are more impaired across the areas, functioning more as a younger child than you would expect for their age. Now, Lynn alluded to the fact that there are more than one diagnostic system, and the systems were generally created to be used in different settings, which is kind of how they evolved. So we've just been talking about the Hoyme 2006 criteria, and we use those in our multidisciplinary clinic here at the University of Rochester, and optimally those are used when you have the combination of a medical provider, a nurse practitioner, a developmental pediatrician, and psychologist or person who does educational testing. We also have a setup here where we have our developmental pediatricians and nurse practitioners who are able to review existing records and can use those same criteria well. However, many of these children are seen in mental health settings and many other places where maybe that kind of gold standard multidisciplinary model is not available. And so within the DSM-5, there's been efforts to increase capacity by providing criteria for mental health psychiatrists, clinicians, psychologists to be able to recognize the neurobehavioral impairment that many of these children have, and can use that to help guide treatment and inform next steps for children. So within the DSM-5, within the last section, pages 798 to 801, are the criteria for a condition called neurobehavioral disorder associated with prenatal alcohol exposure, or NDPAE. And for these criteria, you need to have more than minimal documented exposure of alcohol. You need to have at least one area of neurocognitive functioning, and this can be in intellectual functioning, executive functioning, learning, memory, or visual spatial skills, and you can see that aligns actually pretty well with the Hoyme criteria. You also, in criteria C, need evidence of self-regulation problems by one or the following of attention, impulse control, or mood or behavioral regulation. And then you need evidence of at least 2 areas of impaired adaptive functioning. On here you can see at least one of them has to be either communication or social communication, but the other ones have to do with daily living and motor skills. Now, you may also notice this is in the section of conditions for further study. However, there's this interesting kind of loophole within the main section of the DSM under the other specified neurodevelopmental disorder 315.8, where they specifically list neurodevelopmental disorder associated with prenatal alcohol exposure that you can use and documented with this code. For assistance in thinking about how to use the NDPAE criteria and ways to best document that, there is a nice publication here that the reference is cited for you that you can read and refer and think about using how this might help you in your practice. Now I'm going to transition into talking about FASD-Informed Care. I mean, ultimately, at some level, I don't care what you call it. What is really most important to me is that these kids and families are getting the supports and services that they need, and providers who can use that information to best serve them. But ultimately, as we know, diagnosis often helps you access those services or start to understand better what you're dealing with. But let's talk about what FASD-Informed Care really looks like. So the first thing I want to introduce you to is a very practical resource that's available to you for a free download. It was developed by SAMHSA, and it's called the TIP 58 Treatment Improvement Protocol. And it has practical tips and forms that are useful for providers as well as agency administrators. It gives a lot of useful information about what FASD-Informed Care is and how to do it, and some very useful resources. So the link is here on the slide, and I really encourage you to download this and consider how it might be useful for you, because many, many people are seeing FASD in their practice and may not know it. So next I want to continue with this quote by Dan Devowski. He says, "We must move from viewing the individual as failing if he or she does not do well in a program, to viewing the program as not providing what the individual needs in order to succeed." And so I really challenge you all to think about this and think about clients or patients that are in your care who may really be struggling in achieving success. And so start to question whether some of these folks may actually have a prenatal alcohol exposure condition that might be impacting their ability to be successful, and then what you might be able to do about that. So in essence, there are a number of steps that are involved in FASD-Informed Care. Any of these that you are able to do or consider in your practice will be helpful. So the first most important thing in doing FASD-Informed Care is identifying it. So being able to ask questions about prenatal alcohol exposure, taking a very non-judgmental stance, changing our viewpoint in our culture from seeing alcohol use as a moral legal problem to one of that it is a brain disorder, and thinking about, when asking this question, how can I support the person to give them the space in the room to talk about their experiences. We want to act to prevent maternal drinking during pregnancy, and the most useful, helpful thing in this regard is providing accurate information. So us as providers, being able to be current on our knowledge about alcohol use and how it can impact throughout the entire pregnancy, and try to correct some of that misinformation. There's a lot of tools. NIAAA has a number of resources, as well as the CDC, that can be very useful for this. The next is to carry out diagnosis. If you're a mental health provider or psychiatrist, the NDPAE diagnosis could be very useful for you. You may also find that referring for a specialized FASD diagnosis might be an approach you take. There are, as you'll see in a bit, unfortunately few providers that offer specialized diagnosis, but we are really encouraging others who might be interested to start to learn and see how they might be able to do that. And we have a strong interest in increasing access in the state. The next is to begin planning interventions to reduce risk factors, things like adverse childhood experiences that can increase risk and increase the likelihood that symptoms will impact their everyday functioning. And at the same time, enhance protective factors. We know a lot of these kids have experienced trauma and other life challenges, so the more that we can do to reduce those, but also enhancing those things that we know are protective. So getting an early diagnosis, reducing the number of placement changes for children, having a stable and nurturing home, all of those things can be very useful, and also getting the kids the appropriate developmental services that they need throughout the lifespan. Also working with caregivers to plan interventions. Ultimately, it's the caregivers that often have to carry out these day-to-day interventions to support the children. And it can be a real burnout for many of these families. These kids have a lot of difficulty with impulse control and behavior regulation, are very active and struggle, but many times their behavior is confusing and kind of can be invisible to many people. so these families really need help and support. Continuing, the next couple of points I'll make, I will also expand upon because I see them as being some of the most key skills. The first is this concept of reframing. And what reframing is really starting to change how we're seeing children's behavior and having from a neurodevelopmental viewpoint. So it's looking at the behavior and thinking about how some of these underlying brain challenges may be contributing to the behavior. So moving from a more of a won't to a can't interpretation, sort of thinking out brain-based. So it often leads to more realistic expectations and course helps guide intervention needs and more successful outcomes. We also focus on accommodations. These are things we do to modify the environment, including how we parent, what our expectations might be, and also change what we say and do, and adjust our treatment plan. These kids often need longer, slower course of treatment with more concrete and experiential interventions, and really understanding where their profile of skills lie. The next is using brainstorming. This is another word we often use for positive behavior support planning, really thinking about what the antecedents or what comes before the problem behavior, understanding what need the behavior is fulfilling, and trying to find an alternate behavior that's more acceptable to meet that same need, and putting the responses in place to support that. We want to also be thinking about the readiness to change, and often our readiness to change is the caregivers making changes rather than the individual who has significant brain-based impairment. We often use motivational interviewing strategies to help facilitate families making changes to their approach. And we also can build skills. I think there's some idea that folks have sometimes that these individuals can't build skills or can't do things, and that's not true. They just often need more support and need to have more concrete and longer processes to learn skills. But skills that are often useful for people with FASD include things relating to self-regulation, helping to control their arousal, and other specific skills like memory, attention, and social communication. Safety is often a big one as well. And finally, we need to really think about hope. It can be easy to get bogged down in the day-to-day challenges and the barriers that many of these people face. And so we need to often, as the clinician or provider, help build hope and also think about our own hope in our clients. We need to be, we need to hold the hope sometimes for them, but also inspire that in others. So as I mentioned, I was going to come back and delve a little deeper into kind of reframing and accommodations. So as I mentioned, reframing is this sort of idea of thinking about behavior from more of a brain-based perspective. And so oftentimes you see kind of challenges such as non-compliance in kids and adults with FASD. And our automatic kind of usual interpretation is often that the person's being willful, they're doing it on purpose, they don't care, they don't try, that they're just seeking attention or being difficult. That's what the behavior can often look like. But typically a more accurate or reframed interpretation is that there may be some underlying brain challenges going on, such as difficulty understanding what they're being asked to do, problems taking that information and translating it into an action, things like that. And so this is, once we are able to reframe, it can often help us use a different approach that's more matched to the person's individual needs. And it also often reduces our frustration with the individual and helps that person feel less frustrated too. So accommodations are typically modifications to the environment to support the needs of the individual. It helps create a better fit for the person in the environment. This can be changing what you do as a parent, such as, rather than giving 3-step instructions, only giving 1. It could be changing your expectations for what that person can do. It can also be changing the situation. So if you have a child that gets very overstimulated in grocery stores and has meltdowns every time you go, perhaps you go to the grocery store when the child is in care, or that you go during different times of the day, or you bring things like headphones that will reduce their stimulation. And these accommodations should logically flow from the reframed understanding of behavior. There was a study we did a couple of years ago that really looked at sort of the relationships of some of these things, such as reframing and accommodations. And what our findings supported is that families who had greater knowledge about FASD, maybe they had done some reading on their own or had providers that helped provide them with more background information, were more likely to have this kind of neurodevelopmental or brain-based interpretation, so they were more likely to already be reframing. And from this reframing, they were more likely to use some of these preventive or kind of accommodation strategies. And as a result, these families displayed increased confidence and greater success in managing the behavior. Other families who maybe had less information were more likely to take a willful, kind of more typical interpretations of behavior. They saw their children as being misbehaving on purpose, that they could do better if they tried. And these aren't bad parents. These are just parents that don't know any different. These are kind of some pretty typical interpretations of behavior. And as a result, they were more likely to focus on strategies about after the behavior happened. So consequence-based strategies, punishments, taking things away, timeout, your usual kind of parenting stuff. However, many of these strategies don't work well for kids and adults with FASD. And as a result, these families felt less effective and frustrated. They felt like they were just grappling at straws and nothing was working. And they were feeling less successful in managing behavior. So this really provides a lot of support for really working on reframing and accommodations. These skills sound very easy and straightforward. However, it is difficult to change how we think and act. It can be very, very common to just go into our usual way of thinking. And so it's something that we are always kind of challenging ourselves to do. And it takes some time to change our viewpoint, but these things can really help. The more you can do, the better. And I want to speak to one point that parents often talk with me about in trying to understand why some of our typical intervention strategies, things like timeouts and taking away consequences and those types of things, or even just sticker charts and rewards, things that happen after the behavior. One of the reasons that many people with FASD struggle with this is that, for example, if we use a timeout, what we're trying to typically do is teach the child to pair the problem behavior with something that is like an adverse response. Kids don't like timeouts. So they learn that next time that they face a situation where they could do a misbehavior, that they're going to stop themselves and pick a different choice so they won't have to go to timeout. So they've learned this cause and effect relationship. However, with many children with FASD, they struggle with some of these skills. So, for example, if they come to a situation, they have to, one, remember that what happened last time they were in the same situation as they got into a timeout. They have to then inhibit their automatic reaction, think of a different problem-solving strategy, and then implement it. And many of those things that I just talked about emphasize memory, self-regulation, and executive functioning skills, which are some of the three most impaired areas for most people with FASD. So what really tends to work best for kids with FASD and adults with FASD is to focus on these accommodations, these antecedent strategies. And when they do have problem behavior, because accommodations, they're pretty effective, but you're always going to have some challenges. To focus on a calming response and teaching once the individual is calm. And seeing as this is an opportunity to keep teaching, the more you punish, the less likely that person is going to be successful. So I'm going to move on into what resources are available. I first want to highlight diagnosis and intervention opportunities. So here at the University of Rochester, within the Division of Developmental Behavioral Pediatrics, we have a diagnostic clinic. We have two different models in our clinic, one of which is the multidisciplinary model, where we take more of like a 2/3 of a day, and we do neuropsychological testing as well as a physical exam and provide feedback on diagnosis to the families. We also have nurse practitioners and developmental pediatricians that will see children in a 90-minute visit and review records and do physical measurements and consult in that way. We do have some intervention services as well, doing parent consultation and many of the things such as reframing and accommodations and the brainstorming process we do within that program. There is also a provider, Douglas Waite, in New York City, who will do diagnosis of FAS. Previously, there was a provider in Buffalo. He is mostly retired at this point, so specialty diagnosis is a bit limited. And as I mentioned, is a big need in the community. So if there are people on this call or you know of other folks who are interested in increasing diagnostic capacity, we'd be very interested in hearing from you as we continue to develop in this capacity in the state. There are some family support resources here in the Rochester and Buffalo region. We have support at mHealth Family Center, where I'm also based. Jennifer Faringer at NCADD also runs a support group. Buffalo, they have a support group at ECPASA. There is also some resources near Albany, and Diane O'Connor also does quite a bit of work through Parent to Parent of New York State, and there's a post-adoption resource center as well. In terms of educational advocacy, which many children with FASD need, there are a couple within the state. Starbridge, which is here located in Rochester, actually serves most of New York State, and most of their services are through webinars and phone calls and email. So even if you have clients beyond, I'd encourage you to reach out and contact Starbridge. Also within the Buffalo region, there's Parent Network of Western New York, which is a subcontract of Starbridge. They're both really great resources there. There's also quite a bit of research happening in FASD here in Rochester. And if you have clients or families that you think might be interested, you can refer them to my coordinator, Jennifer Parr, can help join the registry. There's a couple of slides here I'll show in a minute on some current projects I'm working on that might be of interest to hear more about what's happening. But prior to that, there's a couple of books that I recommended. One called Trying Differently Rather Than Harder by Diane Malvin that families really like. It's about, I think, 70 or 80 pages long. It's really digestible, and it talks a lot about these ideas of reframing, accommodations, and parent support. There's also the fantastic Anton series that parents like. There's some resources. NOFAS, the American Academy of Pediatrics, has an FASD toolkit with a lot of resources and diagnosis. NIAAA, the CDC came out with some new webinars and online trainings that are quite good, and several other resources, including understood.org, Do to Learn, or more just general learning challenges sites that our parents like. And then OASIS has some resources within New York State, including the ones I went over on the last few slides, as well as a few additional. I want to just briefly touch on some of the research that we're doing. The University of Rochester is part of the Collaborative Initiative on Fetal Alcohol Spectrum Disorders, where we are trying to all work together and come up with novel ways to identify and understand the impact of prenatal alcohol exposure on development as well as intervention. And one of the projects that I'm specifically leading within CFAS is we're developing a mobile health intervention to reach families, just given the very limited number of providers that have knowledge about FASD. And we're teaching parents based on this program called the Families Moving Forward program, which talks about many of the things that I spoke about on FASD-Informed Care. And it'll include a number of different components, including learning modules, a forum where parents can interact with each other, as well as additional resources that we are currently building. There'll be some trials of this. We're nearing finishing our prototype, and we'll start probably around the late spring, summer, beginning beta testing and trialing to see how well it's received by families and how effective it is in increasing change and outcomes for kids and families. I also have a second study called Tuning Into Kids, which is a focus on emotion regulation. It's, again, another parent program where it's an 8-week group for parents, And it's looking at how parents respond to kids' emotions and teaching them a different approach to really kind of tune in and use some emotion coaching strategies that will ultimately, we're hoping, improve kids' regulation skills and ability to self-regulate. All right, we're right on time. Questions?
Thank you, Lynn and Christy, so much. We're going to get started with a few questions. That came in was specific interventions that you found useful.
Can you repeat that? It cut out a little bit.
Sure. What are some specific interventions that you found useful?
In terms of specific intervention, so the research on intervention efficacy is unfortunately a fairly newer area in the field of FASD. The first few studies were really published in the mid-2000s, right around 2006. But there have been a number of studies that have shown efficacy, and there was a recent paper that I'm happy to send out to anyone who's interested that summarized all of these. But for example, the Families Moving Forward program has had several studies that have found positive outcomes. That's one of the programs that we offer here in Rochester for families, and it's also the one that we're using with the app. There's been some programs that have looked at social skills, safety. There's been some academic interventions, as well as some more parent training type things. The big challenge is that dissemination of these programs beyond kind of the university or an immediate community setting has been very, very difficult. I think a lot of agencies or providers don't see the benefit in terms of the number of kids that they see, even though that many of them are likely seeing more than they realize, or they don't have the capacity or interest or even know about them. So it's been hard to disseminate them more broadly. And so I think that's one reason why some of the resources on FASD-Informed Care have been developed to kind of help people meet clients where they are and with the resources they have available to them.
Great, thank you. Another question is, can you talk through a case example and how you've worked with a family in that way?
Regarding like an FASD-Informed Care kind of example?
Yeah.
Let me think off the top of my head. Yeah, sure. So, for example, there was a young boy. He was about 10 when we first saw him in diagnostic clinic. He was living with an extended relative, and he had, prior diagnosis of ADHD, oppositional defiant disorder, and was really struggling in school, had some special education, and people were wondering, could it be autism? What could it be? So we saw him in clinic, and it was very clear right away that it wasn't autism, even though many of these kids have some social challenges and some kind of rigid behaviors. They look different from kids with autism. So we saw him in diagnostic clinic, did a full neuropsych evaluation, and recognized his diagnosis as alcohol-related neurodevelopmental disorder, which is the FASD without the facial features. But he had confirmed exposure and significant neurobehavioral impairment and memory, executive functioning, and self-regulation in particular. But otherwise was a pretty bright kid with an average intellectual ability, but really struggling at school and home, to the point where police had to be called on several occasions because of his dysregulated behavior. So we then referred him to the Families Moving Forward program, where I worked with him and his family. And we began the program focusing on positive behavior support strategies using the brainstorming process. We really focused on him. He was having a lot of meltdowns, which precipitated some of the police involvement because in the morning with the routine, he really struggled getting all the steps of his routine put together and out the door to the bus, which was very frustrating for him and his family and would escalate. So we focused on coming up with a morning routine that best fit his needs, thinking about his executive functioning problems, having some visual supports, teaching his caregiver another way to kind of respond to his behavior. And we saw a real decrease in the level of escalation. Morning was never still is not an easy time for them, but it's a lot better, and they haven't had to have intervention from the police for a while. After we put that plan into place, we then began moving into the reframing and accommodation section of the program, really helping and teaching the caregivers start to think about some of the underlying brain reasons why the child had a lot of meltdowns and aggressive behavior. As she got better and better at seeing those, we saw a decline in his externalizing behavior, and largely because rather than doing a lot of punishments and yelling, which she had prior done, which is not an unusual response for that kind of behavior, she started instead kind of using fewer words herself, trying to stay calmer on her own and not kind of fueling the fire, and gave him opportunities to calm and some strategies to help with that. And so that was really meeting their needs. We also focused a lot on caregiver self-care, managing all these different behaviors, and the, behavior plans are really draining, and thinking about where her social supports were, how could she find time for herself, figuring out respite and coordinating with other services in the community. And we did a lot with school advocacy as well. We went into the school and helped the teacher and the school team understand his neurobehavioral profile. I consulted on his individualized education plan and his behavior plan at school probably 3 or 4 times during the school year. And so that's just an example of sort of what that might look like for a given case.
Awesome. Thank you so much. I think that's actually all we have time for. So Lynn and Christy, I want to thank you and everyone else for attending today's webinar. Thank you for the presentation. And I want to let everyone know that the slides will be up on the CTAC website within the next 2 to 3 days. If you have any questions or concerns, please contact us at ctac.info@nyu.edu. Once you leave today's webinar, you will receive a survey on the presentation, and we'd appreciate if you would complete that and provide your feedback. On behalf of CTAC and our presenters, thank you for joining us today, and have a great rest of your day. Bye.